السلام عليكم ورحمة الله وبركاته. مساء الخير على حضورنا المميز. نرحب بكم مجددا في ثالث لقاءات دورة الأشعة العضلية الهيكلية، والتي تقام برعاية جامعة جدة وبتنظيم مشترك من نادي جراحة العظام ونادي الأشعة. أنا عادل الزهراني، نائب قائد نادي جراحة العظام، ويسرني أن ألتقي بكم اليوم في محطة جديدة من هذه الدورة، حيث نواصل رحلتنا العلمية لاستكشاف جوانب متقدمة في مجال التصوير الطبي والتقنيات التداخلية المرتبطة به. محاضرتنا لهذا المساء ستكون بعنوان الأشعة التداخلية في الجهاز العضلي الهيكلي، ويقدمها لنا الضيف الفاضل الدكتور حسن الصايغ، استشاري الأشعة التداخلية، حيث سيأخذنا في جولة علمية ثرية حول الأدوار المتقدمة للأشعة التداخلية في التعامل مع المشكلات وإصابات الجهاز العضلي الهيكلي. نذكركم بأن تسجيل الحضور سيكون في ختام اللقاء، فكونوا معنا حتى النهاية للاستفادة الكاملة. والآن نترك المجال لضيفنا الكريم الدكتور حسن الصايغ. حياك الله يا دكتور، المايك معك.
شكرا لك أخي العزيز على الاستضافة. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. I'm Hassan Sayyag, a Saudi board certified musculoskeletal radiologist and currently doing a diagnostic interventional MSK and spinal radiology fellowship at UBC, Canada. So I'm really thankful for this invitation, and I expand my gratitude to the organizing committee and also the participant here in the talk today. Overall, I'm going to talk about an overview of musculoskeletal interventional radiology. I'll put some uh, heads up regarding the common examples of the MSK interventions and also present some of the equipment that we commonly use in MSK intervention as well. And also, I'll give you some examples, like real clinical scenario example, how the role of MSK interventionist can really improve the outcome of the patient, which is really failed the conservative treatment and not candidate for any surgical intervention. I'll try to sum up all these information within 1 hour or 1 hour and 20 minutes, so we don't get bored during the presentation. So moving forward with the clinical case scenario, we have an elderly patient with a lot of comorbidities, including hypertension, diabetes, heart failure, with severe knee pain. We did an X-ray, which is one of the initial exams that we do for any knee pain, which shows really bilateral severe osteoarthritis. Usually after that, we provide the patient with conservative measures, and usually this patient will like respond for a moment, and because of the multiple drugs those patients with comorbidities that they are taking, so they try to avoid having more drugs. Then they will seek the surgical consultation with the orthopedics to give them the option of total knee replacement. Unfortunately, most of them will not be a candidate for total knee arthroplasty because of the comorbidities and the high risk from the anesthesia point of view. So those patients are will stuck in the middle, so they cannot proceed with the conservative management and the long-term painkiller intake, and they are not surgically candidate. Here, the role of MSK interventionist comes. So, what alternative that we can provide to those type of patient? This is an example of bilateral knee osteoarthritis, severe knee osteoarthritis. So, the examples that we can provide is temporary knee joint injection for pain relief, diagnostic therapeutic nerve injection around the knee joint, cryoneurolysis, cryoablation, radiofrequency ablation, chemical ablation of the nerves around the knee joint. This may be overwhelmed. We're gonna talk in the presentation briefly about each of these type of intervention, and this is really an good advancement in terms of pain management done by the MSK interventionist to avoid the high risk procedure and to provide long-term pain relief for such a patient. Moving to another example, we have a middle-aged patient, active player and national club team, has acute shoulder pain, especially in active abduction and internal rotation, not responding to conservative management and physiotherapy exercises, failed also the conservative measures in terms of medical management, and been referred to the MSK interventionist for further investigation and management. So one of the critical aspect of being a MSK interventionist that we are dealing also with the active athletes, and we need to provide an accurate diagnosis and further management if possible from a MSK intervention point of view. So knowing the anatomy is also essential to be an MSK interventionist. As you see here, the ultrasound, if you don't have good interpretation of the ultrasound for this type of patient, this will lead to a failure of management and failure of choosing the management option as well. So we have a grayscale ultrasound here with different type of structures being seen and scanned. And this patient is showing a full thickness tear, which is manifested here as a hypoechogenicity on the ultrasound goes all the way along the fiber of the supraspinatus tendon. So as a MSK interventionist, if I see such a type of injury with focal full thickness tear of the one of the rotator cuff tendons, I would say this is not a candidate for an image guided procedure to provide for this patient, and I would refer this to an upper extremity surgeon to be managed by that surgeon, because sometimes those patient goes to some specialist and they will do certain type of treatment and may cause worsening of the pain rather than improvement of the patient symptoms. So going with this scenario, we're gonna touch upon different type of procedure and possible alternative options for those patients who stuck in the middle and in the medical system, and to provide them with the solutions that will be best for them and having better outcome with a minimally invasive guided procedure. This is a good metaphor for intervention radiology in general, and I would say MSK intervention in terms of orthopedic procedure. I would say MSK intervention in the surgical arm of radiology, and we mainly use minimally invasive technique and under image guidance. As an introduction of MSK intervention radiology, it's a developing field bridging the gap between the non-surgical and surgical intervention. Mainly, we use minimal invasive technique under image guidance, and to be interventionist in MSK or any interventional radiology specialty, you need to have deep knowledge in terms of anatomy, dealing with the imaging modalities and the biomechanics of the body, pharmacology, complication, prevention of such an injuries or pathology, and you should be also oriented about using different technique by doing it in different imaging modalities. So we will see a lot of overlap nowadays between the MSK interventionists. So you will see sport physician doing the MSK interventions, orthopedics as well. You will see rehabilitation, medicine, physiotherapist, um, all of these, like anesthesiologists doing this intervention. There is no wrong in doing this intervention if you have these pillars before doing any MSK intervention. So let's talk about the type of machines or imaging modality that we use. So one of the common encountered cases in MSK intervention that patient comes for diagnostic and interventional procedure under ultrasound guidance, and this is the most commonly used machine that we use in MSK intervention. So this is an example of ultrasound machine with different probe. Usually we use the linear probe because it's also good for superficial structures. Hockey stick probe, usually also we use it for the very superficial and small structures such as the wrist and finger. This is an example of the CT scan machine if you haven't seen one before. So we have the gantry here, patient will be on the bed, and we have also a monitor to do a sequential images to make sure that we are targeting the correct location, and we'll go through cases later on. And this is an image of the fluoroscopy machine. So we will see different type of angio suite and fluoroscopy machines that use only one X-ray machine, or sometimes you will see like luxurious angio suite rooms using a pipe planer machine. Like in this room, we have one machine goes from the side to side, and one machine goes from top to bottom. And this is really helpful and making the procedure faster, especially if you have like a very complex major procedure. In terms of comparison of these different type of machine, every machine imaging modality have its pros and cons. So for ultrasound, you'll be having faster procedure. You will have like scanning. You can do dynamic maneuvers for the patient. You can position the patient and make the patient comfortable as the operator doing the procedure. However, it's an operator dependent. If you don't have the enough expertise utilizing ultrasound, it will be very challenging for you, and it's also ineffective in case of bone and air-filled anatomical structure. For a fluoroscopy, it's a real-time information, especially for the bone intervention. It has less radiation. You can do dimensional view, especially if you have the pipe planar fluoroscopy X-rays. However, it's less precise than CT. CT usually is the best in terms of accuracy. However, it provides high dose of radiation and takes more time doing the procedure as well. So I try to simplify the type of intervention that we do in MSK. I would say maybe will be like the easiest way to classify it. Either we do a oncology intervention and non-oncology intervention, either diagnostic or therapeutic. Moving forward to the types of oncology intervention, we do a ablation that include the bone ablation, soft tissue ablation, nerve ablation, and we'll have few examples. Also, we do different type of biopsy under image guidance, and that include bone biopsy and soft tissue biopsies, targeted nerve plexus blocks, neurolysis, uh, fixation, especially for sacroiliac joint fracture dissociation, embolization usually done by the vascular intervention, but you will see sometimes MSK interventionists also doing some embolization of certain tumor before surgical resection, cementoplasty, kyphoplasty, and also sclerotherapy, especially in cases of, for example, moral lavage lesion, which is a shearing injury of the soft tissues. Sometimes also we tend to provide a treatment for a certain bony tumor, such as unicameral bone cyst or aneurysmal bone cyst as well. For the non-oncology intervention, usually we deal with sport degenerative related intervention that include joint and spine intervention. Recently introduced the orthobiologics and regenerative medicine, especially for the tendons and joints, muscle, tendon, nerve, and ligament intervention, and also headache intervention. To summarize, what's the purpose of doing all this procedure? So I would say either of these 3 points, either to provide a pain management, whether it's a temporary or a long-term or long-lasting pain management. We can use it as a diagnostic tool, for example, as a pre-surgical planning for certain type of a procedure, especially for the orthopedics colleagues or for the spine surgeon or a neurosurgeon's colleagues, and also to promote and enhancing the healing process of certain pathologies. In this image, you will see different type of needle angles going all the way to the vertebral body or around the vertebral body. So based on just only the angulation, you can target different type of structure. So Starting from left to right, you will see a needle goes inside the disc space of the vertebral body. This is a discogram. Also, we use it as diagnostic or therapeutic intervention, uh, especially for patient having discogenic pain, and the physician wanna just to make sure is really the pain comes from disc or from somewhere else. Transforaminal epidural or nerve block. Usually we select one of the nerves comes from out of the spinal cord, and we inject it with mixture of medication for either pain management or for a specific diagnosis. Facet block as well, epidural injection also to provide usually long-lasting pain relief. Selective nerve block again, and sympathetic ganglion block, usually for palliative treatment for certain type of malignancies that's involving the sympathetic chain. This is overwhelming. I try to put like most of the procedure that we do in one slide. If you want to take a picture of it and read about it later on, but usually these the most commonly encountered procedure that we do an MSK intervention. This is mainly, I try to summarize the nerve-related procedure going from the spine to the trunk to the lower extremity and the upper extremity. So we have the like different referral from different specialists to do this procedure, and sometimes we also have our own clinic seeing this type of patient and trying to also gather the history, doing physical examination. If possible, we can do also a dynamic ultrasound scanning or even request a cross-sectional imaging to look for certain pathology, and based on that, we can proceed with one of these procedure. And this is a summary also of articular and extra-articular procedure that we do. So we do a lot of tendinosis, partial tear of the tendons, plantar fasciitis, trigger fingers, different type of syndrome that include carpal tunnel, tarsal tunnel syndrome, intersection syndrome, impingement, Steinbeck syndrome, Morton's neuroma intervention, and different type of joint injection. So moving forward with the this procedure, it's really you need to be oriented about the pathology, imaging, reading the imaging by different technique. That includes CT scan, MRI, X-rays, to know what pathology that you're dealing with, and also correlating that with the clinical symptoms that the patient comes with. Also, other intervention that we usually do also, especially in tertiary centers, which is biopsies, different type of biopsies and ablation. That includes soft tissue biopsy, ablation, bone biopsy, and ablation, especially in cases of osteoidosteoma. Nerve ablation and neurolysis, usual of palliative treatment, and post-amputation chronic pain or phantom pain. Sclerotherapy, that include unicameral bone cyst and aneurysmal bone cyst. We'll have also an example of that. Moral level lesion, sclerotherapy management, ganglion cyst aspiration, and sclerotherapy as well as popliteal cyst. In terms of cystoplasty, this is one of the major procedures that we do in MSK intervention, particularly for the osteoporotic compression vertebral fracture or metastatic compression fracture, as well as certain type of bony tumors. So we finished with the like overview of different type of procedure and MSK intervention. You can drop the question anytime if you have have any question regarding this procedure. Um, and we are moving to the second section of the talk, which is different type of equipment. I'll move quickly about the type of equipment, so at least you know what's it, like having an idea what usually common equipment that we use in the MSK intervention. So one of the real important tools that we use is the needles. Like needles is our life in MSK intervention. You can do like 90% of the procedure by only using the needles. So a common needle that we use is the Quinky needle. As you see here, you have the bevel cutting edge at the tip of the needle. And the two-way needle is a different type of needle. Usually use it for a spinal intervention. There is a certain technique to drive the needle and to steer the needle, as you see on your right hand. If you need to have like to be very skillful in using this type of technique and doing be professional and doing the driving and steering of the needle to target your pathology or lesion during the procedure. This is one of the essential like skills to be an MSK interventionist. These are different type of radiofrequency cannula ablations. So we have like the monopolar type of cannula. We have the bipolar, which is basically just two needles with two active tip, and we do a like large cross-sectional area of burning at certain type of temperature. You use this for nerve procedure. We use that for also bone tumor, soft tissue tumor ablation. We have here the venom type of cannula, which is basically goes at the side, opposite to the bevel edge. And also we have the trident type of cannula. So each of these cannulas we use it like for different type of procedure, and the pre-planning of the procedure is important to choose which cannula you should use at time of the procedure. One of the trending procedure nowadays, it's only approved on US. I'm trying my best to also grab of these type of needles to utilize it also in Saudi, which is basically called the basivertebral nerve ablation. It's a type of a curved needle goes all the way through the vertebral body, and we targeting the basivertebral nerve. And usually we use it for the patient who having chronic axial lower back pain. You will do the MRI. The MRI will be negative for any disc pathology, any nerve pathology. But the only thing you will find in MRI is just signal alteration at the end plate of the vertebral body, which is basically an inflammation of the intravertebral fibers of the vertebral body, and we target these nerves by using this needle. Try to ablate those nerves, and the patient will have pain relief for the rest of his life because only doing this minimal invasive guided procedure. This is an example of a cryoablation needle. As you see here, they have the needle tip and a formation of ice ball around it. And also there's a gross example of ice ball formation and the size of the ice ball. Usually we use it for like 80% of the cases for post-operative pain, chronic pain, and sometimes also a trending like a procedure in terms of cranioneurolysis or cryoablation of a specificity um, patient. So we try to target the motor nerves for this type of patient and to relieve the spasm of the muscles. And also we use it for soft tissue tumor ablation. This is one of the also handheld type of cryoablation system. So that's include the nitrogen cartridge inside that handheld system, and this is the needle. We attach it all the way to the handheld system, and we have like to do a couple of ice balls for each cartridge, maybe 4 to 5 ice balls we can form from one cartridge of the nitrogen. And this is a just like what the purpose of doing cryoablation, especially for the nerve. And cryoablation, we target the nerve and we try to induce a second degree of injury of the nerve to lose the axon continuity, usually at the temperature of -20 to -100. And this is a reversible type of nerve injury. Usually the patient will have immediate pain relief, and later on there will be a regeneration of the nerve over long time of period. This is an example of the bone biopsy needle. We have here the introducer, and we have here the biopsy needle goes inside the introducer, and these are just a stylet of each needle, usually used for solid bone tumor and sclerotic bone tumor. And in terms of soft tissue tumor, we use the TrueCut biopsy. You have here the introducer, and the TrueCut biopsy system goes inside the introducer, and we can open the notch of that TrueCut biopsy and take the sample. This is the vertebroplasty system. We use it for the kyphoplasty for compression fracture for metastatic bone tumor in the vertebrae. We have the introducer system. This is called the spine jack system. We put it inside the vertebra to gain the height of the vertebral body. And this is the medical cement with that we introduce it inside the vertebral body compression fracture to give the pain relief and also the stability of the vertebral body. And this is an example of a newly invented mixture of the cement. Another kind of vertebroplasty system using the balloon dilatation. Usually it's not used nowadays because of the spine jack system just been introduced recently and have its better outcome than the balloon dilatation. Also, one of the essential equipment that we use in especially bone pathology, which is the RON control system. So it's basically a drill with a introducer needle, pusher, and also biopsy needle. This is just a quick illustration of how we use it. So we have the drill and the sterilized cover, and we just put it at the introducer. We push the introducer all the way to the bone pathology. Then we put the biopsy needle inside the introducer. Then we fix the drill on the biopsy needle, and you will see here the biopsy needle will go inside the introducer all the way to take the sample from the target pathology in the bone. So this type of equipment provide us a quicker, safer, controlled um, way to take the samples from any region from the body. Orthobiologic and regenerative medicine, we also use different type of materials to enhance the healing process, especially for joints, ligaments, tendon, muscle, and nerves. One of the also trending way to provide regenerative medicine for the patient is the PRP, which is the platelet-rich plasma solution. Basically, we withdraw a whole blood from the patient and we put it in a special centrifuge machine to separate the blood component. We target to have like a rich, puffy cut with high volume of platelet, and we put it in a special syringe to separate this blood component. And we mainly inject the buffy cut with little of a plasma to provide the process of enhancement of the soft tissue, whether is it a joint, ligament, tendon, muscle, or nerve. Also, we use dextrose solution, one of the solutions that provide also a good enhancing healing process. We used also in hydrodissection of the nerves, especially in cases of carpal tunnel syndrome or any nerve entrapment syndrome. Also, we use Botox injection to intentionally provide a muscle atrophy for certain type of cases, such as in piriformis syndrome, for example, because usually there will be an impingement and compression on the sciatic nerve. So we intentionally produce an atrophy of certain muscle to relieve or release a nerve by image guidance and a percutaneous approach. This is also a trending in MSK intervention mode, which is basically sacroiliac joint fixation. Not all MSK interventionists having the experience doing that, but it's become a trending procedure. It's minimal invasive. We use a fluoroscopic guidance to do that. Usually, either it's involving the sacral aspect or the iliac aspect, or sometimes sacroiliac joint dissociation, um, which is an indication doing this type of procedure. Moving to the examples of different type of MSK intervention. Before moving to that, before any procedure, we usually do certain type of thing. I have my own checklist um, to check before doing any procedure because it's really essential to have a smooth procedure with better outcome. Usually, reviewing the patient chart is really important and critical to decide whether to proceed with it or not with the procedure. That includes clinical data, lab tests, recent intervention done to the patient. Review all the patient imaging and related pathology, and we may sometimes request some special images such as nuclear medicine imaging, PET scans, for example, SPECT CT scans to have better idea and overview of the pathology. Does the patient need sedation, general anesthesia or not, specifically for ablation, biopsy procedure, or sometimes in cases of pediatric or agitated patient? Explain the procedure and the expected outcome. Because it's really critical to discuss that with the patient. Sometimes the patient have some expectation, and particularly nowadays with using the ChatGPT AI agency to gather some information that may be incorrect. We need to explain to the patient what will be the procedure, what will be the expected outcome, and also I explore the patient perspective. So, as a patient, what is your expectation after doing the procedure? Are you expecting this type of result, or you have like different idea? So we can be in the same page before doing anything. Preparation and setup, it's very essential to have like smooth procedure, doing correct positioning of the patient. Also, as an operator, you should be also comfortable doing the procedure so you don't struggle during the procedure and spending more time doing the procedure. And finally, sterilization. An example of the essential equipment. This is an example of ultrasound setup before the procedure. So we have here a sterilized gel probe cover, couple of syringes, couple of needles, fenestrated drip. We put it at the sterilized area at the patient. Bandage gauzes. Sometimes we need an extra tools based on the type of procedure, whether it's an injection, it's an a biopsy, it's an ablation. So it depends on the type of procedure. Rule and thumb in any interventional radiology subspecialty, you need to choose the safest, shortest approach with less radiation. So keep in mind if you are planning to do any interventional procedure or gonna like apply for a interventional subspecialty, this is should be in mind, trying to doing the safest, shortest approach with less radiation by using the appropriate imaging modality. Quick pause of the beautiful Vancouver Island, that's in British Columbia, and the Providence that I'm doing my fellowship. I would suggest if anyone having any opportunity to visit this place by like doing some workshops or like present a presentation in a conference, it's worth to visit this area. Uh, Moving to the last section of the talk, which is the different type of a procedure and different type of imaging modality. We starting with the CT scan. So starting with the CT guided bone biopsy, we need to check initially whether this is a sclerotic or lytic lesion. So as you see here, if you are not oriented about treating CT scans, so this is a CT of the pelvis. We have here the iliac bones, here the vertebral body, this is the abdomen, and this is the posterior paraspinal muscles. We have here a cortical breach or cortical lucency of the left iliac bone, and this is maybe suspected for an aggressive bony lesion. So we plan a CT scan guided bone biopsy. We put our trocar soft tissue needle. We introduce it all the way to the bony lesion. However, here we have, like, I intentionally brought this image because if you are not really oriented about how using the tools, so they didn't use the appropriate length of the needle, so they end up just touching the edge of the lesion. Couldn't advance the needle more inside the intramedullary component. So this was one of the essential like pre-planning step that you need to know what's your trajectory, what's the length that you need to use for your equipment, and how much you need for to uh, to sample from a certain region, like how many samples that you need. Does it need like a microbiology component or only surgical pathology component to provide to the pathologist or the microbiologist? So it's really essential to do a pre-planning before doing anything, choosing your appropriate equipment, choosing also the appropriate modality to do that. Moving to CT-guided bone ablation, usually we do it for osteodysteoma patient, chondroblastoma patient, palliative treatment for painful bone or soft tissue metastases, and also in cases of soft tissue desmoid tumor. Usually we need a sedation or a general anesthesia for this type of procedure. So as you see here, this is a CT scan. We have this is the anterior proximal thigh muscles. We have here the pubic bone. We have here the distal aspect of the neck of femur, and we have a sclerotic lesion with central lucency. This is usually characteristic for a osteodysteoma. Usually, if we, as a pre-planning scan, we do put a marker at the skin to know our trajectory and the needle axis. Also, at the CT scan machine, we have some laser that we utilize to know what's exactly the cut that we need to go through, and also the angulation of the needle. We introduce now our introducer needle all the way to the lesion. This is the introducer needle, and this is the biopsy needle inside the introducer needle. As you see here, the biopsy needle here, this part only, is representing the biopsy needle which is introduced inside the lesion, and we usually take a sample of these osteodysteoma lesions. We remove now the biopsy needle and we put our radio frequency probe inside, and this is the radio frequency probe with active tip only within the lesion. And we withdraw the introducer needle away because to avoid the conduction of the electrical current, and we avoid the soft tissue injury along the tract of the introducer as well. An image of old machine, which is the radio frequency machine. Now we have like a newer machine, which is like better showing better user interface than that machine. But this is the like a plugin of the radio frequency ablation, and this is a plugin of the earth current. Usually put something with the patient to avoid any electrical conduction um, toward the patient. Moving to other type of procedure, which is nerve injection, we use a CT guidance to target the existing nerve roots at the level of the cervical spine. So we have the vertebral body, the vertebral artery, spinal cord, the lateral masses of the vertebral body, and this is the nerve root comes outside of the spinal cord. So we target these nerves as a diagnostic or therapeutic injection. So this is the pre-planning scan. We put some grid lines, which is a marker to know where exactly are we. These are the markers as you see here, and this is the CT scan of the neck. There is the muscle, the vertebral artery, the lateral masses, and this is the neural foramen. And usually the pre-planning image, we go at the posterior aspect of the nerve root, and you see our needle here with putting contrast, confirming that we are within the nerve root, and also we have epidural component goes around the spinal cord. CT-guided joint injection also. Another example with marker as a pre-planning scan at the expected location of the targeted joint. We put our needle inside the joint. We put some contrast to confirm that with an intra-articular distribution. Scapulothoracic pulsar injection. Usually, it's very challenging to do it under ultrasound, so we use CT scan for this type of injection. So we target this area. Patient will have like chronic periscapular pain or scapulothoracic region pain. So we put our marker again. We put our needle at the expected location of the scapulothoracic bursa. We inject the contrast, and we have distribution along the scapulothoracic bursa. One of the novel techniques that invented by one of my mentor at King Faisal Specialist Hospital, Riyadh, Dr. Sha'lan, he used a single technique to treat unicameral bone cyst. So these type of patients are like usually present at 15 years or 17 years of age with the non-aggressive bony lesion usually in the long bones. So rather than going to the surgical management, we provide them with a technique that we introduce a needle inside the intramedullary bony cavity. We do a washing of the intramedullary component, and then we give a high dose of a steroid. And most of the patients that we have treated, they show really improvement after a 6 week follow-up. And after that, we do like frequent follow-up every 6 week. We have like continuous sclerosis of the intramedullary cavity, and no need for to do any surgical intervention or fixation for those type of patients. Moving to the fluoroscopy now, going quickly through different type of procedure. I believe you have been seeing some procedure in radiology department, which is a arthrogram or joint injection using the fluoroscopy. So there's an example of the pre-planning imaging for shoulder joint injection. We put the fenestrated drip and insert our needle. And this is the distribution of contrast, confirming that we are within the joint capsule of the glenohumeral joint. Another example of wrist injection, pre-planning images. We put our needle at the intra-articular aspect of the wrist joint. We put some contrast confirming that we are an intra-articular distribution, and we identify a triangular fibrocartilage tear through the fluoroscopy machine. That because we have a fluid goes all the way from the wrist joint along to the distal radioulnar joint, which confirming TFCC injury. Fluoroscopy guided bone disc biopsy, usually for vertebral bone lesion, spinodiscus paravertebral mass. This is a CT scan sagittal image of the spine showing eaten vertebral body and disc as well, with also paravertebral soft tissue component. So we plan to do a fluoroscopy guided biopsy. We have our needles on the lateral view and also the AP view. And this is the way we use the arrow control drill to take our sample at the level of the end plate and the disc to have like appropriate sample for diagnostic uh, microbiology result. One of the common procedure also an epidural steroid injection. We target this area of at the area of the spinal epidural sac. And the purpose of this usually the pain management. And this is an example of how we insert our needle and we inject the contrast, and we see the flow of the contrast along the epidural space here. Selective nerve block at the level of the lumbar spine. Usually we have like nerves comes from the spinal cord coursing at the lateral aspect of the vertebral body. Usually we have the bony landmark to target here. Depends on the level of the targeted nerve root. So we put our needle all the way to the expected location of the nerve root, and we have specific bony landmark to do that. And we have the contrast distribution along the nerve sheath of the existing nerve root. Provocation discography, also a trending procedure for discogenic pain. The purpose of that to know whether the pain comes from the disc or from other possible spinal or extraspinal structure. And also we evaluate the patient uh, pain during distension of the disc. So we insert our needle inside the disc and we try to distend the disc and see if the patient having a concordant pain that he used to have before or not. And also we assess structural pathology within the disc. As you see here, this is a normal disc. We use it as a control, and this is the pathological disc. It was a normal disc on MRI. However, when doing the discography, we inject the contrast, and there is a flowing of the contrast outside the disc component goes to the epidural space, and this is the concordant uh, test of this as a provocation discography that we know this is pathological and causing the patient pain. Trending procedure of radiofrequency ablation of the nerves, for example, sacroiliac joint nerve. So when we inject the sacral foraminal nerves and the patient have good response uh, of pain relief, we usually target this nerve and we do a pruning and ablation of this nerve to provide a long-term relief for this type of patient. And we have different technique to do that. And this is an example of that. We have our needles along the expected location of the sacral foraminal nerve roots. We have the spinal needles here as a initial needle, then we'll introduce our radio frequency needle with the trident cannula. As you see here, there is a small linear, uh, like dark lines, which is represent the trident cannula. Also, a vertebroplasty kyphoplasty procedure, different vertebra like cysts that have been discussed earlier. Usually we use it for pain management to the gain vertebral spine stability, and also in case of patient have failure of conservative treatment. So we don't treat any vertebral compression fracture directly. There is certain criteria to do that based on the patient suitability to do the procedure, whether it's painful or painless vertebral fracture, and whether it's a osteoporotic or non-osteoporotic fracture. This is an MRI, a fluid sensitive image. If you are not oriented, usually the acute or subacute fracture represent as bright on fluid sensitive images on MRI. So this is presumably an acute or subacute fracture. And also we have the height loss on the fluoroscopy imaging. So this is a good candidate to do the procedure. We introduce uh, uh, the vertebroplasty system, and we have here the spine jack system to gain the height of the vertebral body. And this is after opening of the spine jack system to gain the height with cement injected inside the vertebral body. And this is the net result with more than 90% pain improvement after the procedure. Intercostal nerve block, also one of the procedures that we do, usually for chronic pain along the chest wall or the abdominal wall. We target specific nerve based on the patient symptoms, and we do inject the contrast before injecting our mixture of medication to provide whether a temporary pain relief or long-lasting pain relief by doing radiofrequency ablation or cryoablation of that nerve. Moving to the ultrasound, very common procedure. We do it daily with many patients. For example, joint injection for osteoarthritis, hydrodistension for cases of frozen shoulder, regenerative medicine to inject the PRP or dextrose. This is an example of ultrasound. We have here the humeral head, the glenoid. There is a fluid inside the joint, and this is our needle goes all the way within the joint space, and we inject the mixture of medication. MTB joint injection. As you see here, this is an X-ray of the foot with severe joint space narrowing of the first metatarsophalangeal joint with subluxation, and being also aware about different type of ultrasound technique. It's really essential because sometimes we'll have very difficulty reaching to some joints. So we have something called in-plane technique, which is the perpendicular to the needle, or the out of a plane technique, which is um, rotation of the probe corresponding to the needle trajectory. And this is an example. So you see here the bony outlines, and this is the joint space, and you see the distension of the joint space while we do give the injection and out of a plane technique. Snapping syndromes of also one of the really common pathology that we encounter. So this is an example of iliopsoas syndrome. So we have the iliopsoas tendon touching all the way at the anterior aspect of the femoral neck. And we do a ultrasound or MRI to diagnose this type of pathology. Then we provide the treatment after that. This is a sagittal MRI. We have the the femoral head, acetabulum. We have the joint capsule, and we have a plaque structure goes all the way. And should be like as a jet plaque structure. However, there is a brightness at the distal aspect of the tendon, which may represent tendon snapping. And this is the dynamic ultrasound before doing any procedure. So we have the iliopsoas tendon. It will be snapped, as you see here. And when the snapping happens, the patient will feel like a sudden sharp pain at that area. So the next step that we do, we introduce our needle all the way and we inject around and within the tendon with a diagnostic injection. If the patient responded, we provide a Botox injection of the iliacus and psoas muscle to provide a long-lasting pain relief. Also common procedure that we do, ultrasound guided microtenotomy or prolotherapy, usually for plantar fasciitis, tear, partial thickness tear of the tendon, and ligamentous pathology as well. This is an example of plantar fasciitis. So we have a coronal image of an MRI of the ankle and sagittal image. This is the central band of the plantar fascia. Usually it should be a thin and a jet black, but we have some brightness and also some brightness around it, which is indicating that there is an inflammation, usually chronic inflammation. And this is an ultrasound. We have here the bone, and this is the plantar fascia, and this is our needle. And we're doing a micro tearing of the plantar fascia, and also we introduce the dextrose or PRP within the component of the plantar fascia to enhancing the healing process and providing a pain relief as well. Usually, the purpose of also ultrasound guided nerve block is diagnostic block, pain management, and usually we target the peripheral nerves. And this is very common uh, clinical setting that we encountered for a post-amputation patient. So patient who comes with phantom limb pain or residual limb pain at the surgical site. And we do a scanning to identify whether there is a neuroma, which is basically a fibrotic scarring nerve causing these either residual pain or phantom pain, and we target that nerve by doing the ultrasound. So here is the nerve of the femoral nerve, and this is the femoral vein, and this is the femoral artery, and this is our needle goes all the way to the nerve. We do a hydrodissection by injecting dextrose or sometimes normal saline, and then we do the cryoablation, which is basically formation of the ice ball. So this is the ice ball starting to forming. It's difficult to be visualized under the ultrasound because it's a solid structure. So as you see here, there is a post-acoustic shadowing or post-acoustic darkness, which is indicating there's an ice ball formation, and the patient will have immediate sharp pain, and after that, a long-lasting pain relief. Moving to the ultrasound soft tissue biopsy. So this is a CT scan of the back. As you see here, if you compare this area to this area, there is some swelling here within the posterior lower back muscle, which is indicating a lesion with also permeation of the bone of the transverse process of the lower lumbar spine. So since we have a large soft tissue lesion here, we can just do a ultrasound and we guide that uh, uh, needle toward the soft tissue lesion with also discussion with the sarcoma orthopedics or the spine surgeon because we need to have like multidisciplinary discussion before doing any biopsy uh, for a as a pre-operative planning. So we have our needle here, and this is the area of the soft tissue lesion, and we advance it all the way to take the sample using a trocar biopsy. Also, one of the pain management procedure that we do is the calcific tendinitis borbotage. So usually this patient comes with the severe shoulder pain and calcification along the rotator cuff tendon around the shoulder. We do the ultrasound scanning. We make sure this is really the pain generator in the patient case, and we after identification of the calcification, we introduce our needle and we try to break that calcification and aspirate that calcification, and usually this will be the net result. As you see here, the sedimentation of the calcification within the bottom of the syringe, and patient will have immediate pain relief after that. In terms of complication, we have general complication and a specific complication for centering procedure. So bleeding, infection, nerve damage, failure of procedure is one of the like main point in any general procedure, and this could be an expected complication. As a specific complication may be related to major procedures such as kyphoplasty, vertebroplasty. We have encountered leakage of the cement within the disc, within the veins, sometimes the epidural space, refracture of the vertebral body after treating it, rigid spine, venous leakage as well. Cervical nerve block is really critical area, so there is a possibility of penetrating the vertebral artery, and once you penetrate the vertebral artery, there will be high chance to have a showering emboli to the brain and high risk of having tetraplegia, paraplegia, and possibly brain death. Proactive discography, commonly encountered discitis. That's why in those type of cases we give them a prophylactic antibiotic to avoid discitis. For ablation procedure, thermal injury usually the commonly encountered complication if it's not being done properly. Quick example, kyphoplasty case, cement inside the vertebral body, and this you see this linear bright line. This is a venous leakage around the vertebrae, and also here there's an epidural leakage of the cement. Another example, fracture treated with cement, fracture again, refracture of the vertebral body. If the patient not treated properly for osteoporosis, that's usually the result of that. Moving to the end of the presentation, we have the take-home messages for anyone gonna do an MSK intervention or planning to enter an MSK subspecialty, especially the interventional part. Appropriate pre-planning imaging is mandatory for any procedure. Careful correlation with the clinical symptoms to avoid doing a unnecessary procedure. Again, safest, shortest access with less radiation, and appropriate training using the appropriate equipment is also essential to have a successful procedure. The beauty of being a MSK interventionist, you have immediate outcome, improving the quality of life, newer medical techniques to apply every day, and rewarding outcome as well. Careful if gonna have any vascular or non-vascular interventional rotation or being involved in an intervention. Please don't come inside the angio suite not wearing the lead apron or the protective measures for radiation. We have like many medical student, sometimes resident, comes inside the angio suite unprotected, and because we are doing the procedure, we don't see them, so they have exposed to like radiation unnecessarily. If you have any question, please feel free to ask. I hope I have finished on time, and thank you so much.
شوف إذا في أسئلة بس. في
الله
بعض
يعطيك الف
الأسئلة يا
عافيه
دكتور
دكتور
في
نجم. اي تفضل.
صندوق الدردشة، في بعض الأسئلة من ممكن تطلع عليها من نفس الشات.
اي اي، هذا انا فتحت الشات الان، ثواني بس. Doctor, can you describe the feature of osteoarthritis? Yes. So, in terms of osteoarthritis, it's very important. Osteoarthritis is essentially evaluated by only doing X-rays. Please don't ask for CT scan, don't ask for MRI. The optimal assessment of osteoarthritis is X-rays. So we're looking for any joint space narrowing, we're looking for any osteophyte formation, we're looking for any subchondral changes within the bone. Usually, you will see lucency at the joint, like the subchondral line. Um, Patient usually will have a severe pain, mechanical pain. So there is no point of doing any cross-sectional images for this patient. Sometimes, if you are already in doubt, you can just call the radiologist, Msk Ir radiologist, and he can tell you what exactly going on with this patient. Allah يعافيكم إن شاء الله. So we have a question here. What are the training pathways of for a Msk interventionist from radiology track? A good question. So talking in Saudi Arabia, we have being a Msk interventionist, not really well established. We, after finishing a 4 years of radiology residency, usually there is still a low exposure to MSK intervention, and trying to um, look for a fellowship training program doing a lot of MSK intervention will be your target at that time. Um, I'm aware that there is certain institution in Riyadh doing a lot of MSK intervention. You can ask the colleagues who done the program at Riyadh in those institution, and you can have like an overview of what type of procedure they do. Is the fellow really involved in the procedure or not? And based on that, you can decide whether to go to that institution to have proper training in MSK intervention. There is another track to do MSK intervention internationally. So sometimes there is some institution in Canada, UK, accepting a radiologist to do an MSK intervention uh, as a radiology track. Sometimes there is a pain medicine fellowships accepting the radiologist, and sometimes other specialties that include orthopedics, family physician, anesthesiologist to do also MSK intervention. Um, Sometimes sport physician fellowship in UK doing also MSK intervention. So there is a flexibility to end up to be an MSK interventionist. However, you need to look for the appropriate institution that to provide the uh, the expectation that you're looking for to be as MSK interventionist. So, and like to sum up, look for what thing that you need and you want to learn. Look for the institution, go to the conferences, ask about institution doing an MSK fellowships and training, and try to apply to this institution to have the expected outcome of the training at this institution. الله يعافيكم إن شاء الله. Um, so we have a question. Do you recommend a hybrid fellowship in both diagnostic and interventional MSK, or diagnostic then interventional? Also, as a radiology resident, where do you recommend taking an observership in Canada during my training? Good question. I would say diagnostic MSK radiology is essential. To be a good interventionist, you should be a good diagnostician as well. Because I saw a lot of cases been treated يعني بدون انتقاص للأذر specialty for example the pain physicians the anesthesiologist doing some certain type of procedure they are good in doing that but sometimes because disorientation of the anatomical structure of reading the pathology on cross-sectional imaging might end up with like failure of procedure or even complication to the procedure. So being a good diagnostician is essential to be a good interventionist. بالنسبة للأذر part of the question, do you recommend any observership in Canada؟ طبعا I'm not the one expert to ask بالنسبة للobservership في كندا لأن أنا فقط عندي experience في single institution في يو بي سي. يو بي سي نتكلم عنها أننا في two institution which is the BGH and اللي هو فانكوفر جنرال هوسبيتال، وفي عندنا سانت بولز هوسبيتال. سانت بولز اللي أنا موجود فيه هو اللي يقدم أكثر spinal pain procedure and ultrasound oriented diagnostic and procedures. فإذا كان طموحك to go for these two kinds of like procedures بتكون يعني البست في بي سي انك تروح لسينت بولز. بالنسبة للفي جي اتش they do lot. عندهم طبعا lot of things to do from diagnostic part perspective وفي intervention perspective. They do more complex procedure. They do like the cryoablation using the larger machine. احنا بس نستخدم الهاند هيلد machine. Also, they do a lot of vertebroplasty. They having like different type of rounds مع الانكولوجي، مع الروماتولوجي، مع السبورت physicians، مع الاورثوبيديك، الابر اكستريميتي، اللور اكستريميتي، orthopedics. فممكن يعني based on انك تسأل each مثلا MSK radiologist graduated from different institution في كندا، تاخذ مثل ما نقول اللي هو الاكسبيرينس البرسبكتيف عن التريننج بروجرام، و based on that you can decide whether to go for an observership or not. الله يعافيكم. During a CT guided procedure, do IR physician are exposed to the radiation throughout the procedure? Yes, it depends. طبعا بالنسبة للسي تي فيها تفصيل. في عندنا something called biopsy mode وفي عندنا non biopsy mode. البيوبسي مود يكون الاوبريتور او الفيزيشن inside the CT room with the patient and he's taking the shots of a scan. طبعا بيكون wearing الليد ابرون. الليد ابرون طبعا يحمي بنسبة 95 ل 99% من الراديشن. however you will be exposed to radiation for sure. ف based on your expertise, based on your comfortability with doing the procedure, you can either choose the biopsy mode أو إن تكون going back and forth. يعني you can scan the patient وأنت outside the room. After the scanning, the planning of the procedure, you go inside, you adjust your needle, you adjust your equipment, بعدين ترجع behind the glass of the CT machine and you do another scan. It depends on your expertise, depends on your comfortability with the procedure. You can whether be exposed to radiation or not. الله يعافيكم إن شاء الله بخدمتكم. From where can we have the goggle eye protection if the facility does not provide it؟ في طبعا بالنسبة للاي بروتكشن في different companies تبيعها. منها الكومباني اللي هو الايمجنج كومباني نفسها، وذر اللي هو السيمنز، فيليبس، جي اي. في براندز تكون اوف ليبل مثلا ممكن نحصلها في بعض المواقع، لكن انا ما عندي خلفية عنها صراحة. بس ممكن لو تعمل سيرش مع الديبارتمنت اللي معك في المستشفى ممكن يعطونك الريسورس اللي هم ياخذون منها الاي جوجلز على اساس الاي بروتكشن. In CT guided intervention, do you do the step then review the CT image again and so on? Again مثل ما تفضلت it depends. Are you comfortable with the procedure inside the room or outside the room? It depends on the type of procedure that you are doing. بعضهم يفضل انه يكون في البايوبسي مود ويكون داخل السيتي روم and he's doing the scan, he's doing the movement of the table. بعضهم يكون outside. Myself, I prefer to be outside. I go back and forth during the procedure. لأن usually اللي هو السيتي procedure بتكون مثل ما نقول very accurate. يعني عادة بتحتاج يعني آه، عدة مرات فقط انك تطلع وتدخل من السيتي روم على اساس انه to avoid the radiation as much as you can. Do you recommend any box for MSK intervention in particular؟ طبعا السؤال هذا بيكون جدا وايد، لأن في بوكس كثيرة وارتكل كثيرة كل يوم تطلع حاجة جديدة. في بوكس مختصة فقط في البين مانجمنت، مثلا articular para articular أو extra articular pain management. في بعضهم فقط للسباينال بروسيجر specifically الانجكشنز. وفي كتب ثانية للنيوروتومي or radio frequency ablation of the spine. فكل يعني different set of procedure بتحصله في كتاب معين وتحصله في ارتكل معينة. بالنسبة لي أنا أستخدم اللي هو الانترناشونال سباين سوسايتي مانوال حق السباينال بروسيجرز بشكل عام، خصوصا الراديو فريكونسي ابليشن بروسيجر. بالنسبة البريفرال نيرف بروسيجر، للنيرف انترابمنت، هيدرو ديسكشن، راديو فريكونسي ابليشن، بشوف اللي هو البريفرال انترابمنت بوك حق اللي هو جانجي، اللي هو البروفيسور جانجي الفرنسي. بالنسبة للريست اوف بروسيجر اللي هو الفلوروسكوبي جايدد، الالترا ساوند جايدد، في كابل اوف بوكس طبعا انا اللي هو استخدمهم واتصفحهم من فتره الى فتره فقط تو ريفيو، بس ما تحضرني اسمائهم الان. لكن مثل ما قلت لك، كل كتاب او كل مثلا بروسيجر في لها different set of references you need to look for. skeletal radiology sometimes يكون عندهم بعض الارتكلز تكون ممتازة، يشرحون فيها بعض البروسيجرز. لكن هذا اللي يحضرني حاليا. بالنسبة للسباين، انترناشونال سباين سوسايتي، البريفرال نيرف اللي هو الكتاب جانجي، وفي بعض الكتب للفلوروسكوبي والالتراساوند جايد بروسيجر. وطبعا بتشوف في فاريشن كثيرة، كل ما تفتح ارتكل جديدة بتشوف different تكنيك، وتفتح كتاب جديد تشوف different تكنيك. ف there is nothing يعني wrong or right. What you think is comfortable based on the experience, based on discussion with the senior colleagues, you will end up with the appropriate technique that you use with comfort. Is
طيب
it
في الخ...
essential to have hand skill or you taking it by practice? Yes, الهاند سكيلز مهمة، خصوصا في موضوع النيدل درايفنج والنيدل ستيرنج. جدا مهمة انك تتعلم عليها في البداية وتجربها على فانتوم فور اكزامبل او مانيكن، وعلى اساسه if you've been oriented before doing that on patient بتكون الامور جدا سهلة عليك لاحقا.
طيب في الختام، شكرا دكتور حسن على تلبية الدعوة ومشاركتك القيمة التي أضافت لنا الكثير، مجهود يذكر ويشكر. الله يعطيك العافية دكتور، ما قصرت.
الله يعافيكم، بالتوفيق ان شاء الله، واي خدمه حاضرين. هذا الحسابات عندكم لينكد ان والتويتر والايميل، لو محتاجين اي سؤال او حاجه بخدمتكم.
الله يعطيك العافية، وشكر خاص لكم جميعا على حضوركم وتفاعلكم الرائع، ونثمن جهود نادي جراحة العظام ونادي الأشعة في جامعة جدة على التنظيم المميز لهذه الدورة. كان معاكم عادل الزهراني منسق الجلسة، ولا تنسون تسجيل الحضور قبل المغادرة، الرابط الآن متاح أمامكم. نلقاكم في اللقاء القادم والأخير بإذن الله، والسلام عليكم ورحمة الله وبركاته.